Ellen, are we all set?
Yes, we are. Let's go ahead and get started.
Okay, great. Thank you. Good evening, everyone. I'm Attorney General Josh Stein, and I have the honor of co-chairing the North Carolina Task Force for Racial Equity in Criminal Justice, along with Justice Anita Earls of the North Carolina Supreme Court. And it's my pleasure to kick off this evening's task force learning session on implementing local solutions to the substance use crisis in North Carolina. I want to thank all of you for joining us and for your interest in finding new ways to better serve your communities. And I want to thank our panelists for being part of today's conversation. We're joined this evening by Courtney Liddle and Justin Wright of Sunrise, Asheville, Chase Hallman, Public Health Advisor and Harm Reduction Lead for SAMHSA, Major Elijah Bazemore of the Durham County Sheriff's Office, Chief Mike Yanero of the Jacksonville Police Department, and Margaret Bordeaux, Justice-Involved Overdose Prevention Specialist with the North Carolina Department of Health and Human Services. And I am grateful to all of them for giving us their time, and they'll be sharing more about their work momentarily. Finally, I'd like to thank Greg Sabin of my office for his work in putting together this evening's informative panel. Governor Cooper created the task force in June of 2020 in response to the murder of George Floyd and the resulting public protests here in North Carolina and across the country. He tasked us with researching and developing real solutions that would address the inequities in how the criminal justice system treats Black people and communities of color. And then we were to work to implement those recommendations. In December, we delivered 125 recommendations, and this year we're focused on making them a reality. A number of the recommendations, including the ones we'll discuss today, involve our state and our country's struggle with substance use disorder and other behavioral health crises. The task force believes that having smart, public health-driven responses to this crisis is critical to improving people's lives, to promoting racial equity and criminal justice, and to keeping our communities safe. Many of these solutions are being driven by local governments. Often, local elected officials and community leaders, including many of you with us this evening, are best suited to find and put in place creative solutions to helping people with substance use disorders by treating addiction as the public health crisis it is. Substance use disorder is a chronic disease. And when a disease spreads across communities, it becomes a public health crisis. Unfortunately, we've become a little too familiar with what a public health crisis looks like after these past 2 years of COVID. But COVID-19 is not the only public health crisis we face. The opioid crisis tragically has only worsened during COVID because of the spike in anxiety, depression, and dislocation. I personally have made combating the opioid crisis a priority since I was sworn in as Attorney General back in 2017. To solve it and other substance use crises, we need to make sure treatment and recovery resources are widely available so people can get the health care and other support they desperately need. Of course, when it comes to addressing a drug crisis, there will always be a role that law enforcement must play, particularly against those who traffic this poison that leads to the misery and death experienced in our communities. But there's a difference between someone whose crime is pushing drugs on others for money and someone whose crime is their addiction, which again is a chronic disease. We cannot arrest ourselves out of a drug epidemic. We tried that during the crack epidemic during the 1980s and 1990s. People then didn't see addiction as an illness or show compassion to those who were waking up every day trying to overcome their substance use issues. The overwhelming sentiment was that this was a moral failing, particularly among Black people who disproportionately suffered from this type of addiction. And we responded as a nation by starting the war on drugs. It didn't work. And more importantly, it was wrong. It was an approach grounded not in giving people the compassion and treatment they needed. I am certain that race played a factor in our national response. We have to do better now. We have to make sure that there are treatment resources available to help people struggling with addiction, whatever type of addiction it is they face. I believe we're making much progress and not repeating the mistakes of the past and thinking that we can somehow arrest our way out of the crisis. But we need to do more than not simply repeat the mistakes of the past. We need to learn from them and continually improve our approaches. My office has worked closely to support law enforcement agencies that adopt new strategies to move people with addiction out of the criminal justice system and into the healthcare system where they can get treatment and become well. Many of these initiatives are part of recommendations from the task force, including responding to 911 calls involving mental health or drugs in a way that ensures people get the services they need. Making sure our law enforcement officers have crisis intervention training so that they can help keep people safe. Funding and increasing pre- and post-arrest diversion programs that help people get the treatment they need. Improving and establishing pretrial services so people with addiction who are not threats to public safety can get substance use treatment services they need. Making sure prisons and jails are equipped to address people's behavioral health needs, including substance use disorders, and decriminalizing certain low-level misdemeanors like simple marijuana possession and handling marijuana use as a public health policy issue as opposed to a criminal justice one. Diversion is a preferred alternative to incarceration for many people for several reasons. At 4 times the cost, prison is certainly less cost-effective than treatment. Helping someone treat their addiction so they get well is better for that person, but also for their family and the community. While in treatment, a person can live at home, get healthy, work, provide for their family, pay taxes, and contribute to the community instead of sitting in jail, which disrupts every facet of their life and costs the taxpayers substantially more money without addressing the underlying core issue of their criminal behavior, which is their addiction. The Durham County Sheriff's Office and the Jacksonville Police Department have been early leaders in creating programs that help people with addiction get treatment instead of prison. And you'll have an opportunity to hear more from Major Bazemore and Chief Yanero on this momentarily. I strongly believe that we should hold drug traffickers and dealers accountable for the harms that they cause. I also believe we should hold the drug companies that made billions of dollars getting millions of Americans hooked on opioids accountable as well. That's why I've been leading a bipartisan coalition of state attorneys general to take these companies to court, and we are winning more than $30 billion so far, almost all of which must go to helping people struggling with addiction. In July, I led a group of states to reach a historic $26 billion bipartisan multi-state agreement with Johnson & Johnson and the 3 major drug distributors, McKesson, Cardinal Health, and AmerisourceBergen. In North Carolina, our share is $750 million for treatment, prevention, and harm reduction services over the next 18 years, with a large percentage being front-loaded in the early years. This massive deal comes on the heels of 2 other significant cases my office helped to resolve that will bring additional funds to North Carolina. A $4.5 billion bankruptcy plan with Purdue Pharma and the Sackler family that will bring about $100 million to North Carolina. And then a $600 million settlement with McKinsey, the consulting firm that advised Purdue for 15 years on how to turbocharge its sales of OxyContin. And North Carolina's share is nearly $19 million. All in, we're looking at approximately $900 million for North Carolina for this crisis. But it's not only about securing meaningful resources for North Carolina communities, it's also about making sure that the funds go to help people and communities in every one of our 100 counties, and with a focus on where the need is greatest. So in April, the North Carolina Association of County Commissioners and my office reached a historic agreement that lays out how North Carolina will use the settlement or bankruptcy funds that come from these various legal actions that I just mentioned. About 15% of the funds will go to the state And the General Assembly will help direct those funds to efforts to address the crisis with the input of the Department of Health and Human Services. Most of the money, 85%, will go to counties and larger municipalities so they can put in place evidence-based solutions that will have the most impact in their communities. It gives local communities and counties an opportunity to work together to find and use evidence-based, high-impact strategies that make the most sense given those specific needs and resources. The agreement puts our state in an exceptionally strong position to help people across North Carolina. Earlier this month, we met an important milestone towards making this national agreement a reality. 48 states and territories signed on to the agreement during the state sign-on period. That broad showing of support meant that we could advance to the current step of the process, which is the period for local governments to join. In North Carolina, approximately 120 counties and municipalities have already signed on to the memorandum of agreement between the state and the local governments. But to make sure we receive all the money that can come to North Carolina under the agreements, every local government needs to sign on to the deal. So if yours has not yet, please reach out to your county commissioners or city councilors to urge them to join the agreement. And then get involved. Help them decide how to spend the settlement funds best in your communities. And I hope that today's conversation helps inspire you with new ideas as to what that means, how to bring to life the treatment and recovery resources that will best serve the people who live near you. So let's hear from our panelists on what some of those solutions might look like. And I'm going to turn it over at this point to my colleague, Steve Mange, who's my policy director, and he's going to facilitate the discussion and then moderate questions. Thanks again to everyone for your participation this evening.
Thank you so much, Attorney General Stein, for those introductory remarks. And so what we're going to do at this point is give each panelist roughly 5 minutes to talk a little bit about their work and the programs they're involved in or their perspective on these issues, and then open things up to questions from, we've got a handful of folks in the Zoom room. We've also got many more listening in on YouTube. So looking forward to a robust conversation. So for lack of a better idea, we thought we would go west to east, from the mountains to the coast. And so why don't we start with Courtney Liddle and Justin Wright of Sunrise Asheville to talk to us a little bit about your work in this area and your perspective on these issues.
Thanks so much, Steve. I'm going to share my screen.
Great.
All right, I'm going to jump into this. I'm Justin Wright, Sunrise Community for Recovery and Wellness, and I'm a person who's in long-term sustained recovery, which means I haven't utilized any kind of substances or alcohol in over 9 years. It also means that I pay my taxes and my family loves me and my employer can trust me and my neighbors don't have to worry about things going missing off of their porch because of my brain disease. It means a lot of great things. It means that I'm thriving. And so thank you for having me and for allowing us just a quick moment of your time to tell you about what we do here. We do a lot of hard things at Sunrise. Summing up what we do in 5 minutes might be the hardest. I'm not sure if that's possible, but we're going to give this a shot. And I'm just going to jump right in. We are 100% peer support run and operated. Peer support somebody with lived experience in substance use and or mental health struggles, who then partners with other people who are in the midst of that and helps them towards recovery, whatever that looks like for them. And as a peer agency, we are a recovery community organization. And what that means is that for this side of the state, the western side of the state, we're kind of like the umbrella organization for peer organizations, and we provide peer technical assistance and pass-through funding to other recovery community centers, and anything that has to do with peer support and what a peer does in a specific role in a provider agency, or how to become an agency that raises up peer supports for drop-in centers. All of those types of things are things that we counsel on or give technical assistance on as a recovery community organization. A lot of training for the community goes into that as well. So that being said, I'm going to hit our first, I think maybe 5 programs again, very briefly, and then I'll pass this over to Courtney here. Oh, on the front end, I just wanted to throw this out there. I noticed in the notes that any kind of data that might be useful or cost savings for local governments about what we do as opposed to what's being done already in the field would be useful. And I just wanted to throw this out there. This past quarter that we just had, at least for Sunrise Community, our agency as a whole increased 47% in the number of touches that we have with people, which is a huge deal. 47% within 3 months is huge, which means that we're not even touching the needs for those that we're trying to support. And so there's plenty of need, and the workers are few. So I know that this is about getting more workers out there. And just for reference, December of this year, Sunrise Community had 17 employees. As of right now, we have 52, and that's because of the need. And so we're trying to meet people where they are, but there's too many hurting people out there that need people like you and like us doing the good work. Now, our first program is actually the Recovery Community Center itself. So it is like the hub of Sunrise. It's where people can come just to hang out. They can come to get support groups of any kind. So we have 12-step who can come in there. We have Smart Recovery, Refuge Recovery, peer support groups. We don't believe that there's only one pathway to recovery. We think there's as many as there are people. And so we try to meet people where they are in that. But our Recovery Community Center is that safe place where they can come. They can have a peer support who is with them to help them fill out resumes, or to give them some peace from being out in the rain if that's the deal, or help them find housing. It's just a safe place where good people are there to connect others to community resources in the area, and also to support them where they are. So this hub of Sunrise, our Recovery Community Center, then kind of branches out. I see it like a weird octopus in my brain, right? We're the hub, we're the brain, and then we have all these tentacles. So one of our tentacles is this Blair H. Clark Respite Center. The respite house that we run is a peer respite. It's the first of its kind in North Carolina, and it opened back in 2017. And this is a place where people can go who aren't in mental health crisis, but they're struggling with mental health. So they're feeling overwhelmed, they're feeling stressed, but they're not in crisis, and they just need respite. They need peace. Someone can show up to that respite house. They can stay for a week, and a peer support is staffed there 24/7. They can interact with them. There's no requirements for groups or anything else for them to show up. They can just be, and then we can support them where they are. And we provide food, we provide rides if they need to go to the store or whatever else. And we're just there in the midst of their pain and providing space and safety for them to try and get some mental capacity to kind of move forward with whatever they're trying to accomplish with their health and wellness. Next one here's
Justin and Courtney. I need to move you all along a little bit. Running low on your 5 minutes.
Okay. Let me see what I want to jump to here. Courtney, I'm actually going to have you select what you want to talk about. If you heard anything, hear this. The people who have been through substance use and mental health struggles are the people who can connect the quickest a lot of the times with those who are going through it, and the needs there for more peer supports. Courtney?
Yeah, just real quick, and I know we don't have much time. My name is Courtney Liddle. I'm a person in long-term recovery from substances and mental health difficulties. I'm also a peer support specialist and a recovery coach. I find strength and purpose in relating to folks and supporting individuals on their own pathways to wellness and recovery. I think some of the cool things that Sunrise does is we partner with Buncombe County on a lot of different programs. One of those being the Linkage to Care program. So this program provides peer support and other resources to individuals post-release from jail and prison. The Sunrise Peer engages with those who have recently been released and provides support for up to a year while also addressing their social determinants of health needs. We also operate a syringe service program, the SSP at the Buncombe County Health Department, where we provide sterile injection equipment, naloxone, linkages to supportive services, and overdose prevention education. And then another thing that I think is really important, all of it's important, but is our MAT program in the jail. We have partnered with Buncombe County Detention Facility to provide peer support for individuals who are part of the medicated assistant treatment program And this provides treatments to individuals with opioid dependency who are housed at Buncombe County. A Sunrise peer is able to provide individual peer support and resource coordination to individuals while they are housed in Buncombe County Detention Facility, but also when they are released, so that they are able to maintain that connection. I feel like my time is near.
Well, fortunately, we have the Q&A as well. I imagine there may be questions about the tremendous value of having peer support programs and peer run programs. And so thank you very much for that kind of introduction to some of the life-saving services that you offer. I'm now going to move from the mountains to the Triad and let Chase Hallman talk to us a little bit about some of the work he's been doing in Guilford County and beyond. Chase?
Hey, good evening. I appreciate the opportunity to be up here and share a panel with such talented people that I respect and admire. My name is Chase Hallman. I'm a clinical social worker and a clinical addiction specialist. I'm also someone that's been directly impacted by substance use, and in ways like I've overdosed multiple times, and I've been involved with the justice system. And I also was privileged enough to be offered evidence-based treatment instead of serious jail time, and resources to transform my life, including education and housing and employment and other things that come along with being able to avoid the justice system in a significant way. I'm actually, I was introduced as my new role at SAMHSA. I'm truthfully between jobs right now because I don't start till next Monday. But in my former role, I directed a program called Guilford County Solution to the Opioid Problem. And I have done that for the last 4 years. At GC Stop, we're a partnership between Guilford County, primarily emergency services, and the University of North Carolina at Greensboro Social Work Department. That partnership has included a post-overdose response team with Guilford County Emergency Services, in which we've worked together. We've had a champion with the director of EMS here, Jim Albright, and folks have been, asked if they want to be reached out to by someone with lived experience following an overdose. And I've worked with EMS to, help coach them on how to talk with people, do some cultural humility training with people who use drugs. And, beyond that, we've had a number of other services that include syringe services, where we give sterile injection equipment to folks, and teach them strategies to reduce their risk for overdose and, other life-threatening illnesses like hepatitis C and HIV, endocarditis, bloodborne pathogen type stuff. We've had a justice involved program heavily informed by Margaret Bordeaux, who we have here, that helped us get that started, where we've gone into the jails and spent time with folks. We've been able to get them custody releases out of jail into treatment providers or even to our custody as a harm reduction service provider, which has been amazing to get folks out of somewhere where it is not very helpful and in fact harmful to somewhere that can help better their life. And we have a hepatitis C program. Most importantly, though, I would say that the partnership between the county and university has been very special in that, we have, academic type people who can academically validate what we're doing and study it and evaluate it, as well as being in the social work department. I was able to get my licensure throughout this process and not just be a peer, but someone that is able to provide licensed counseling, specifically addiction counseling. And we have about 12 students every year, both graduate and undergraduate, that are in social work school, many of them with lived experience of drug use that have been in the collegiate recovery program, that are able to provide counseling and case management underneath my licensure. And what we've seen has been just fantastic results. And I think truly because of the partnership and the team effort between the university, county officials. We've had law enforcement partnerships that have just really blossomed over time. And then also the meaningful inclusion of people with lived experience. We have Louise Vincent in the Urban Survivors Union right here in Guilford County. And we're so fortunate to be able to build off of the work that her and her group have been doing for well over a decade. And I think because of that meaningful inclusion and partnership, that's what has enabled us to have success. Just in the last year throughout all of our programming, I've got some stuff written down. We saw 778 unique individuals in Guilford County. Over 300 of them were new contacts that came and saw us. We set up at motel parking lots. We do outreach, the EMS referrals. We see people in jail. So that's kind of how we meet folks, and meet them where they are and just offer them kindness and resources as we can. We pass out close to 6,000 naloxone kits and, hundreds of thousands of syringes. And the best part is, what we've heard about, which is, and this is just what folks have told us when we've asked, 1,287 people had their life saved with the naloxone distributed by another person who uses drugs. This is naloxone we gave directly to people who use drugs. And that's 1,287 families that don't have to bury their loved one in the last year. And that's only our numbers. Urban Survivors Union has well over 1,000 as well. We were able to link 63 people to treatment in the midst of the pandemic. So that's a low number for what normally is during our years. And really it's just a testament, to what can be accomplished when, county officials and public safety and other folks can get together and well-equipped people with lived experience and social workers and everyone else with the resources they need to make an impact in the community.
Thank you so much, Chase. Those are amazing and very moving statistics. Thank you for sharing. That. Continuing our journey along Interstate 40, veering up on Interstate 85, let's turn things over to Chief Bazemore in Durham. Tell us about what you're doing.
Good afternoon. And can I share my screen too?
Should be able to.
Okay. I guess that didn't work too good, huh?
I can see it.
You see my presentation?
Yep. Do you want to click the little screen in the upper left? There you go.
Okay.
Yep.
All right. We're doing medication assisted treatment here in Durham County. Just a little bit of background of how we got started. In 2017, North Carolina Association of County Commissioners came together, charged all 100 counties to come together and start kind of treating the individuals that have a substance use disorder, opioid, and of course the concern was opioid. They developed a steering committee called Durham Joins Together. It seems like a long time ago, but in October of 2019, I was volunteered to join this committee. And as a result of joining this committee, we created yet a subcommittee. And the whole purpose behind this was how we could start MAT here in the Durham County Detention Facility. And we have named our Sheriff's Medication Assistant Reclamation and Treatment Program. And the whole purpose behind that is to eradicate the stigma that's attached with treatment. And what we're trying to do is ensure individuals that are detained who have an opioid use disorder that are willing to receive treatment are afforded the opportunity to get treatment while they're in facility. We feel it's just a matter of time based off the 8th Amendment in the 4th Circuit, I think it is, up in Boston or one of the upper states. They lost a claim for failure to provide treatment to an individual that had an opioid use disorder. So we're trying to stay ahead of that curve here in Durham and get individuals that need this service assistance. As we came together as a committee, it's a daunting task of how you will start and get everything up and going. We originally started out with probably a 4-phase plan, but we eventually moved it back to a 2-phase plan, phase 1. And what we're actually in phase 1 right now, where individuals that come in the facility, if they are receiving treatment in the community, we simply continue their treatment. Phase 2, we're going to actually start induction, and we are real close. We're doing some stuff now, but we haven't officially moved into it. How did we get to where we're at? It's a collaboration and a partnership from the community. The Sheriff's Office, Durham Public Health, our medical provider, Durham Health Worker Fit Program, MAT. We also have a peer support, external peer support, Durham County Criminal Justice Resource Center, Mental Health Services, the STAR Program, Alliance Health, big partner, Durham Recovery Response. We know them as Recovery Innovations, Duke University and UNC. So we meet on a regular basis, where we actually have a small subcommittee meeting probably weekly. The challenges for getting a program of this magnitude up, funding. The grants have been very difficult because of when they start and when they end and actually getting the money. And but we have had some successful grant, some successful grants, and that's the challenge, getting grants and getting them in. Our stats to date, we've been afforded the opportunity to treat 149 individuals, 93 Suboxone, and of those individuals, 73 males, 20 females, 56 with methadone, 44 males, and 12 females. As of January 11th, 2021, and mind you, this program started in September 2019. Our average length of stay for the individuals on Suboxone is roughly around 16 days, and our average length of stay for the individuals on methadone is 17 days. By making this treatment a standard of care, we increase the opportunity to improve community outcomes in Durham County, reducing the overdose deaths in the community, reducing recidivism, because again, we have an internal connection and we have an external. We have a discharge planner, and we kind of do a warm handoff to the peer support in the community. It's going to reduce unemployment and increase family stability.
Wonderful. And we will hold questions for the general Q&A session. Thank you so much, Chief Bazemore. And you can stop sharing your screen.
I'm trying to figure out how to do that.
Should be a big red button somewhere. It says stop sharing. Might be either, yeah, there you go. You did it. Well, continuing our march toward the coast, I'm going to now recognize Chief Yanero to talk to us about some of the initiatives he's been involved in his city of Jacksonville and in Oslo County and beyond. So, Chief, the floor is yours.
Well, welcome from the coast. You know, this has kind of been a journey for us. It actually started in April of 2016 with the Castlight study that came out and indicated that Jacksonville was number 12 in the nation for opioid abuse at about 8.2%, which is about 16,000 people in our community of 70,000 people. Along the same lines, we were in a staff meeting talking about some issues that were occurring in our community, and the officers that were in the staff meeting actually talked about issues that were related to mental health. And so we started to go back and look at what those issues were. And we found in a year period that we had a 136% increase in overdoses, a 7% increase in drug-related incidents, 106% increase in crisis intervention calls, 26% increase in attempted suicides. 58% increase in child abuse and neglect. And of the 263 children in foster care, 65% of those cases had substance abuse as a contributing factor. Then we looked at our arrests. Out of roughly 5,000 arrests, about 50% of those arrests had something to do with some type of substance abuse. So we started to look at actually what we were doing as far as spending police officers' man hours. And in 2016, we spent 16,000 hours dealing with these types of calls. That's the equivalent of 11 full-time police officers at the cost of $1 million to the city. So we brought that to the city council, and they understood the severity and the urgency of the opioid crisis, and they wanted to streamline treatment. So we had a number of barriers that we had to look at. One is, because we're a large military community, active military has services on Camp Lejeune. And so our community didn't have a very robust mental health system. So we were interested in a quick response team, a post-overdose team, a leads, try to do some type of diversion team. And part of those issues for us to get those programs started was the inability for us to have treatment. And so the city and the county commission came together and they formed a mental health task force. And in April of 2019, we were able to open the Dix Crisis Center for short-term crisis. Around that same time, one of the things that we did was we contracted with TASC, Treatment Alternatives for Safe Communities, and the Center for Health and Justice. And they provided us kind of like a roadmap for us to look at. And so we took those reports, and we also took some support from UNC Chapel Hill School of Government with their SOAR program. And so we were able to have a strategic plan, and we looked at what we could do to develop first using the Dix Crisis Center as the lynch piece, and giving us an opportunity to divert a lot of those folks that we were arresting into some type of treatment. And actually, we were starting to see some progress, and then COVID hit. And COVID has tremendously increased the need in our community. But that plan allowed us to look at a number of different things, that plan from TASC. One thing that we did find out is there is no formal process for us linking people with opioid at the point of release for Dix. And as part of our process, we were doing opioid fatality reviews. And the reviews indicated that there was a gap in service from Dix. And so we applied for a COSAP grant, and we got several different things with that COSAP grant. One is we've got a counselor that's addressing crises within the school system of folks that are either overdosing or having some type of crisis related to opioids. The second thing that it allowed us to do was to hire some peer navigators. So once somebody comes out of the Dix Crisis Center, those peer navigators are giving opportunities to get them into long-term treatment, to get them into housing, to get their welfare, to get food stamps in order to get them back on their feet. And that program has been very successful for us. But the need is much greater than simply we need additional resources. And so the other thing we've been working diligently on is the process of being able to get folks into long-term treatment. There's been a number of barriers, and the community came together and raised some money. And so we have a fund through our Onslow Ministries, which is our local shelter that provides processing fees for folks to get into long-term treatment. And we have several folks that are in long-term treatment now, because typically when those folks would come out of the Dix Crisis Center, they would have a number of challenges. And one of them is that they've used up most of their family resources. A lot of times the families don't want to have anything to do with them, and they have no real funds. So the ministries has allowed us, once they're ready, to get them into long-term treatment. And so we have a number of folks that are in long-term treatment, but we see the need. You know, when I tell people that we've spent $1 million of their tax money on just dealing with those, and you know, really the only thing that you have to show for that is folks in jail, I think they start to realize the need for a robust diversion program, for a robust post-Dix Crisis Center program. And I think we're starting to see the benefits of that as we move forward.
Thank you so much, Chief. Appreciate you sharing that, not just some of the programs, but the journey that has gotten you to where you are. And I now want to recognize our final panelist, Margaret Bordeaux, to talk a little bit about your perspective from DHHS.
Thanks so much, Steve, and everyone. Just really honored to be a part of this panel, simply because I've worked alongside many of the other panelists for quite some time now, and I appreciate that shout out, Chase. But this is all really important to me. As AG Stein said earlier, I'm the Justice Involved Overdose Prevention Specialist. I'm coming from the Department of Health and Human Services Division of Public Health in the Injury and Violence.
I'm not hearing Margaret. I don't know if that's on my end or Margaret's end.
Right around the time that, I'm sorry, can you all hear me? Yeah.
I lost you there for a second, but I don't know if that was me or you. I'm sorry. Go ahead.
It may have been me. And if it happens again, I'll shut my camera off. That seems to work a little.
All right, we'll let you know.
All right. And so came right around the time that Durham is having, you know, when Chief Bazemore was being voluntold about the jail-based MAT program, that is when I came into my role. Prior to that, I worked at a community-based organization, North Carolina Harm Reduction Coalition. I'll name drop because I know a lot of folks are familiar with that program. And so I worked here in Wilmington in New Hanover County, where I'm a native and a resident. And so I did community outreach. And so I worked with different communities, and one of the communities that I worked with that was really important to my role there and my role now is the folks who were residing at the New Hanover County Jail. And so I co-instructed an overdose prevention and survival course at the New Hanover County Jail. And I did that with my boss at the time, and we did it for a while. And it was one of those things that just happened. She invited me to come, and I was like, I don't think they want me at the jail, just because my life prior to that had brought me into the jail in very different ways. So I was like, if I can pass the process to be a volunteer, I'm all for it, but no hope, right? And so they let me in. And so it was just a great opportunity. I learned so much from spending, that 3 hours every week at the New Hanover County Jail with those folks. And one of the things I used to do after the class was over was get in my car and I say, I wish somebody was doing this all across the state, right? And so I would do it every Wednesday, and I actually manifested the job I have today. And so we have to be careful. There's power in our tongue, because when the job description came across my desk, I said, oh my, this is what I said I wanted to do. So I had to apply, and I'm glad I did. It's another one of those things where I'm like, no way DHHS wants to hire me. No way CDC Foundation wants to hire, someone like me with this lived experience coming from the background which I have. And the bottom paragraph said, we welcome those with lived experience around justice involvement, around substance use. Words matter. These things are really important. And so I was like, if not you, then who? And so I applied, and that is what really informed the work I do today. Like I said before, and it's not for play, it's for real. The best part of my job is learning from other panelists and learning about other programs that are happening in North Carolina. That's really what's been informing and advancing the work. Everything that I share with Chase is the things that we learned in New Hanover County, and now Chase can share it with others. The same way that I learn about what Sunrise does with Buncombe, and I connect them with other programs that we work with and say, these guys are doing peer support really well. I want you to talk to them because they're the champions. So I don't take my role lightly, and it's just a lot of liaison, and it's keeping a lot of information here. And so one of the things that we have been really fortunate to start doing, and Steve's been a part of that too, and A.G. Stein, is we're really going to inventory all of these successful programs. We're really going to have some lists and some resources available, like a resource hub, to really put that information out there. With $900 million coming into the state, there's no way that me, Margaret Bordeaux, can still do the connect people here and there. So we have to have strategic ways that we can help counties think about how they will spend this money, how they will use this money to really have impact on the citizens and the residents in their counties and municipalities, because this is what it's really all about. As somebody who is coming from community-based side, and we would always dream about what would happen if the settlements would happen and if we would get this funding, how we could just really make a lot of impact and just see meet people, continue to meet people where they are, but have the funding to do it. One of the things that I've noticed, and you all may have also with all the panelists, they describe resources is really critical, right? So if it's not funding, it's also like having the manpower and the staffing. And so this is just a great opportunity to continue the work that we know we've been having success with. We have the models, we have the folks, and again, it may be a little disconnected somewhat. We're bringing it together, but we do have an infrastructure here in North Carolina, and I always like to remind folks of that.
That's great, Margaret. Thank you so much for sharing your journey with us and some of your insights. And I do agree with you that just as peer-to-peer interaction is a great way to help people on their journey in recovery, I think peer-to-peer education is really one of our most promising ways to spread best practices, to spread evidence-based practices. As I think many people on this call know, Lars Paul in Fayetteville, who ran their LEAD program and was such a leader in diversion programs. And the first time I ever met with him, he came to the Attorney General's office. And one of the very first things he said, I got to tell you, this is really important. Meat eaters only listen to meat eaters, and grass eaters only listen to grass eaters. And so if you want cops to do something, you got to get other cops to tell them what to do. And if in this case, we want county commissioners to do something, I think we need to get other county commissioners to tell them what to do, and so forth. And so I think that really is going to be a key to success in the way we move forward on the opioid settlement funds. We are kind of transitioning into the Q&A, and Margaret, I did want to ask you, since you have this statewide, since it's your job to have this statewide perspective and to be dealing with lots of people and different types of programs, I want to start with this question with you and then maybe let others chime in. Since we're talking about recommendations from a task force on racial equity, talk to us a little bit about how the issue of racial equity comes into play in sort of setting up and managing some of these programs. What challenges arise, what opportunities arise? How do you build equity into these programs?
Thanks so much. This is a great question. And so I'll just be my radical self and just start by saying I think $900 million is a great way to start having some of these equity conversations, right? Realizing that we've had limitations in the past, and so we have to deal with like the presenting emergency, and it was overdose, right? And so we couldn't peel back as many layers as we maybe needed to, because again, we didn't have the resources. So I think it'd be in all of our best interests is if we went into planning for how counties are going to use these settlement dollars, is to think about it from an equity perspective. And something that AG Stein said earlier that really stuck with me, because I think about it a lot, this will be a great opportunity to practice some reconciliation and some restoration in those communities that were hit hardest when we did not have the public health approach, right? When we had that more punitive approach. Folks are still dealing with some of the consequences of what happened then. So those communities may need some of that funding to support them to really dig themselves out of the dark places that they may have slipped into. For me, this is, I just think it's really important to have folks from those racial demographic groups a part of these discussions, right? And so I think, again, centering lived experience looks really different. You know, my lived experience is very different than Courtney's, whose is different than Chase's, who is different than Justin's, right? But we all have some, right? But as we talk about racial equity, we want to open more opportunities from folks from different demographic backgrounds to be a part of those conversations. I can do my very best, but I know that I don't represent all Black women. We should have more opportunities for other Black women who have had stories that may be similar to mine, but just a little bit different. And also, other racial ethnic groups. We have to look at our American Indian populations in North Carolina who carry some high burdens of overdose. And so just make sure that folks are included in those conversations from beginning all the way to service delivery. Because again, like you said, Steve, having folks that you can connect with, that have shared experiences, is a great way to talk to folks. So having that lived experience and having representation throughout programming and planning.
Thanks. I may circle back with other panelists on that, but before we do that, I know we have at least one question, possibly more, from our audience. And so, Greg, did you want to share any of the questions that have come up, and then I'll maybe quarterback those, or anyone can jump in on them?
Sure. We have one question from YouTube, and if people in the Zoom environment or on YouTube have questions, feel free to put them in the chat or the comments section. This one's from Caleb, and it's for Chase. Chase, you spoke about the college recovery experience. Are there specific solutions that have been more successful with North Carolinians in college or younger that need more funding?
I think collegiate recovery programs have been very well funded in North Carolina for the past few years. Since they started, you know, we were an early leader in that and received a substantial amount of funding actually from the governor's office some years back. I know that that has since been cut off. But I know that there's lots of leaders. There's a new hire, Jared Michael, for addiction professionals in North Carolina, who is the new director of scholastic recovery. I would encourage folks interested in collegiate recovery in North Carolina to reach out to him. And he's had a lot of experience directing a program in East Carolina. But I think that collegiate recovery programs are very promising and producing a lot of people who go into the field to help others.
And Chase, what was that name again of the gentleman at APNC?
It's Jared Michael Harris.
Okay. All right. If folks would like to track him down, you can send us at DOJ an email. We'll make that connection. Were there any other questions, Greg, that had come up from our folks who have been listening to the panel?
That's all we have so far, but
okay.
Happy to take more if folks have them.
Absolutely. Interrupt if others come up. I did want to circle back to the question I asked Margaret and kind of open it up to some of the other panelists. And I'm particularly interested in the question of building racial equity into into the types of programs that you're running and sort of the nuts and bolts of that. Like, is there particular demographic data that you sort of build into that you collect or build into your program, or any comments on the actual like nuts and bolts of having a racial equity lens?
I'll jump in here if that's all right.
Great.
First, Margaret, when you were talking, I was on fire for it. When you were talking about how people who are experiencing any kind of oppression are the people with the lived experience that we need to be talking to. I don't know, I was jumping out of my seat, because something we realized at Sunrise is if we're asked to implement any kind of program or peer support program in any community that does not look exactly like me, then cultural competence is just like a fake thing that might not ever happen, right? Like, we can try to get close, but we're not ever going to be fully culturally competent, which means that any of our work is not going to be sustainable. We're going to go in and out, and that's not going to be useful to that community. So for us, we try to raise up people from within those communities that are already community leaders who can then sustain the programs in ways that matter to that community, not to Sunrise or to anything else. And we can do that with money. Right? That's how we can do that. We can pass the power along and our seat at the table, but we also do it with the funding that we receive. So I just wanted to say thanks for that. And then as far as the nuts and bolts that you're talking about, Steve, I think that at least for our company, Sunrise, because we are in a very much predominantly white area here in Asheville, North Carolina, and a huge starting thing for us is to all be on the same page that there is still racism, that there's systemic racism, that there's a crazy amount of bias, that we each hold blind spots, and getting that base level of understanding, acknowledgement, acceptance, and then now what is always like kind of the hardest thing to do before you hit that tipping point of now where's the action. So for us, we've implemented some actions, but looking at hiring practices, going through all of our wording for all of our internal and external documents to see if they're inclusionary and they're focused on accessing services for not just us, but like as white people like me, but for anybody who we serve in our community. Those are some of the things that we do, but that base level of understanding, I think for any company might be useful.
Great, appreciate those comments. And we are bumping up right here at 7 o'clock. I did want to see if any of the other panelists just wanted to contribute on this issue of building equity into programming. So I'll throw that open for a minute before we wind things up. All right.
I just think,
go ahead, Chief.
I think it's crucial that you have diversity in the programming. And if you build diversification in the programming, then you can't stir wrong. A lot of times, and when we are building programs, I think we miss some key opportunities to make sure we'll take care it being as inclusive as we necessarily need to be. And so you have to tap in to every available resource to make sure you're not excluding anybody that's going to need this help.
Mm-hmm. That's great. Appreciate those comments. Well, we are unfortunately at 1 minute past the hour. So I just, on behalf of Attorney General Stein and the Department of Justice, wanted to extend a heartfelt thank you again to all of our fantastic panelists. I've got a pad of paper here with like 50 more questions I was writing down as each of you were speaking. I guess that could be the next panel. But really admire your passion and your thoughtfulness in implementing these programs, and your expertise will be very much needed. I mean, it's always needed, but it's going to be even more needed in the coming years as we're looking at how best to spend this the opioid settlement money and how best to implement the recommendations of the task force on racial equity in criminal justice. So thanks to you, thanks to all of our audience members, both in Zoom and on YouTube. And I hope everyone has a wonderful evening. Take care.